Dr. Milan Khara, Dr. Milan Khara joined Vancouver Coastal Health in 2003, having previously worked as an addiction medicine consultant at CAMH in Toronto. Certified by the American Society of Addiction Medicine, his current work primarily focuses on treating tobacco use disorder, but also extends into other areas of tobacco control. Clinical commitments include leading the St. Paul's Hospital Smoking Cessation Clinic. Dr. Khara has also been involved in the training of health professionals to optimally treat tobacco use disorder, including supporting the CAMH Teach project. More recently, he has been involved in initiatives to combat the rise in electronic cigarette use in high schools, speaking with legislators, educators, students, and parents. He is a clinical assistant professor at the University of British Columbia. Research interests have mainly focused on hard-to-treat populations and have been published in medical journals. Dr. Khara has been involved in many areas of tobacco control advocacy, including providing testimony in challenges to smoke-free legislation. And he has appeared as an expert witness before the Standing Committee on Health to contribute to the development of a federal regulatory framework for electronic cigarettes. So join me in getting ready for what I'm sure will be an interesting subject. And I will take myself off and allow you to share screen, Milan. If you're having any issues, you know Lori is there to screen share. Thanks so much for joining us.
Okay, so I think I am successfully sharing my screen, and I assume that everybody can hear me. Thank you, Jennifer and Laurie, for introducing me. Thank you for inviting me to speak this evening. It is a pleasure to do so. It's still afternoon here in Vancouver, but I will get on with my talk and try and leave lots of time for conversation at the end, not least because I have a sniffly nose and I think an hour and a half might be the doing of me, but I think there is great value in having an exchange of ideas and thoughts around approaches to treatment in this population. And I think the expertise in this room, this virtual room, I'm sure is greater than mine alone. So I think that will be time well used, I hope. Okay, my own land acknowledgement, of course, I'm here in Vancouver, on the west side of Vancouver, and I also respectfully acknowledge the land on which I work, the traditional territories of the Coast Salish people, the Musqueam, the Squamish, and the Tsleil-Waututh nations. This is my disclosure slide. I work for Vancouver Coastal Health and Providence Health, so two of the British Columbia health authorities. I've received funding in the last 12 months from only two other bodies, that is TEACH, that's the Centre for Addiction and Mental Health in Toronto, and our Doctors of BC, which is our formerly, no, the Doctors of BC. I'm sure you all know what the Doctors of BC are. Now, two things on the disclosure. One is that I have no pharmaceutical industry funding to disclose in the last 5 years. I actually did have a relationship with pharmaceutical industry before that, around 7 years ago, but that is no more. And I at no time, past or current, have tobacco or electronic cigarette industry funding. And I make that last point simply because there are people in this space who are talking particularly about vaping, who do have relationships with the electronic cigarette industry. And that's for those individuals to deal with their own consciences and whether that is an appropriate financial relationship to have when talking to healthcare professionals about the pros and cons of e-cigarettes. But I just want to make it very clear that I have no such funding. So I'll be talking about all smoking cessation medications today. It's almost exclusively from published research. I'll be talking about off-label applications of some of these medications. And as always, we'll be happy to take any specific questions that you may want to throw at me if you feel like there's bias or if you feel like anything is unbalanced or not reasonable. That's absolutely fair game for asking me questions about it, as it always should be. Okay, so you saw a a quick scan of this slide a few moments ago. So this is the learning objectives. Really, it's actually the three sections of the talk. The first section, I assume, is simply review for everybody in this audience. So talking about the neurobiology of tobacco use disorder, talking about the treatments for tobacco use disorder. And by the treatments, I mean the pharmacological, the patches, the pills, etc., and also the non-pharmacological. This is just going to be review. You don't need me to talk to you about non-pharmacological treatments. You don't need me to teach you about motivational interviewing. There are people who are far more skilled than I am in those areas. But I will reference these things, not least because clearly behavioral counseling, these non-pharmacological approaches, independently improve the likelihood of cessation, as do medications. And when the two are combined, that has a synergistic effect and gives us the best outcomes possible. So a bit of a quick review of stuff that I think you already know, but maybe some references to off-label or aggressive approaches from clinical practice can be sort of suffused into that to give you a bit of a view into the clinical world that I live in. The second section is focusing on so-called hard-to-treat populations, or the specific populations of those with mental illness, with other substance use disorders, sometimes with both. And this is clearly not a footnote for most of the people who are on this call. This is the population that I think most of us work with. And this is the population who are left behind using tobacco. So this is really where we need to start focusing our attention. If we're ever going to be successful in these very ambitious goals to get to less than 5 by 35, these federal goals, then this population that's been left behind, that is increasingly representing the tobacco using population, is the one we need to get our head around when it comes to treatment and think about what kinds of approaches are going to work. And then the last section is thinking a little bit about vaping as harm reduction potentially, vaping as a cessation intervention, and also thinking maybe for a moment about how we treat those who are compulsively vaping and want help to stop. And I've also included other new potential treatments in that sentence. It seems strange to put vaping in the context of anything new. Vaping's been around for 20 years, but clearly it is a growing and evolving conversation in the world of tobacco treatment, and that's the reason why I think some of us still think of it as new. So those are my objectives, or those are the kind of three parts of the talk, and as I said, lots of time for discussion at the end. And if there's anything that hasn't been covered that pertains to tobacco treatment or to vaping or to anything else that we talk about, very, very happy to revisit it and chat. Okay, so always a good place to start is kind of taking the pulse of where we're at. And I'm sure everyone knows that we've made great progress in this country. When we look at the smoking prevalence rates on the left of this slide in the mid-60s, we were above 50%, certainly above 50% in men. And we've had this really nice, pretty well straight line fall down to the 15% or so that you see in this slide. The reason it's 15% is that it cuts off in 2013. But if you extended the slide a little, you'd see that by 2022, we're down to around 10% smoking prevalence rate in Canada. And of course, the reason for this straight line reduction in prevalence rates is manyfold, but the things that we've done in tobacco control have worked quite well. So smoke-free public places, warning labels on packaging, all these things that have come together and have denormalized smoking, with the increasing recognition of the lethality of smoking in concert, have led us to have this really very nice fall off in prevalence rates. Despite that, tobacco use still remains the leading preventable cause of death in this country. Around 37,000 deaths that are attributable to smoking. So if we didn't have this cigarette smoking in this country, there would be 37,000 less premature lives lost. 1 in 2, maybe even 2 in 3 of all long-term tobacco users will die prematurely from a tobacco attributable illness. And the average loss of life is estimated to be around 10 years. But the last bullet on this slide is where I want to focus some of this conversation, and that is that this is an epidemic of death and disability that is now largely focused in those with mental illness and substance use disorders. And this is an American stat, but 44% of all cigarettes smoked in the US are done so by those with mental illness. This is a rather old slide, but making the point from the reverse perspective. When we look at people with, on the left of this slide, schizophrenia, with bipolar disorder, on the right of this slide, those with alcohol and cocaine and opioid use disorders, we see that the smoking prevalence rates clearly are not in line with that 10% prevalence rate that we see across the general population. Clearly, these patients are much more likely to smoke cigarettes, maybe not in these kinds of numbers today, but if you think of the populations that you work with, I'm sure you would agree that more than 1 in 10 of those patients is smoking cigarettes. In fact, it's many-fold that kind of number. I won't spend too much time on why today. The why is actually a really interesting conversation, and there are many threads to it. But just if you think for a few moments about the way we've viewed those with schizophrenia, where we've seen very high smoking prevalence rates, there's been all kinds of hypotheses, but the self-medication hypothesis has been quite kind of seductive, really. The idea that people with schizophrenia who smoke cigarettes have an improvement in their psychiatric symptoms or an improvement in their already impaired cognitive functioning, and even a reduction in medication side effects. All of these things have been somewhat plausible and somewhat attractive, but they've also tied into a culture within the mental health service system where tobacco use has been considered allowable or even in fact encouraged, and cigarettes being provided as reward, cigarettes being removed as punishment. These are practices that still remain, and cigarettes dispensed from the nursing station. Again, practices that I've seen very recently, even though it's in contravention of British Columbia law. So the self-medication hypothesis, the shared genetic vulnerability hypothesis, the culture, it's pretty complex interplay of factors that are likely leading to these high prevalence rates in these specific populations. Now, if we just pivot for a moment, we talk about the lethality of tobacco. We talk about the 10 to 14 years of life that are lost in those who smoke cigarettes. But one of the messages that we maybe don't emphasize as strongly is the benefits of cessation, really the other side of the coin. And this slide highlights that. If we look at the top right-hand graph, what you see here is a survival curve comparing current smokers with those who have never smoked in this blue line here. And in fact, that blue line is 2 lines. It actually includes those who have quit between the ages of 25 and 34 and those who have never smoked. And the reason you can't distinguish those 2 lines is that, in fact, on average, if you quit young, if you quit between the ages of 25 and 34, you lose no years of life. You get those 10 years back effectively. When we look at the next graph, one over, and now we look at those who quit between the ages of 35 and 44, we see now there is a bit of a gap between the never smoked line and the quitters line, but still most of those lost life years are gained back, 9 years are gained back. And then I'll get you to jump to the last graph that I've got here on the bottom right-hand corner. This is those who quit between the ages of 55 and 64. And you see that even those individuals on this survival curve are getting some years of life back on average. These quitters are less likely to die prematurely than those who continue to smoke. The message from this slide really being 2 messages. One, if you quit young, you avoid almost all of the negative health impacts of cigarette smoking. And the second, arguably more important message is that it's never too late to quit. And I think the reason that's an important message is that there are many of our patients who have used tobacco for many decades who have a sense of hopelessness, partly because of their repeated failed attempts to quit, but also partly because of the decades of smoking and the belief that it's just too late to get any benefit. And I think we need to be shouting this message out loud and clear that it really doesn't matter how old you are, but if you quit, you will, on average, gain life years back. So back to people with psychiatric disorders. Clearly, there's been limited efforts to treat this population, not least because providers are mostly not trained in how to treat tobacco use disorder. When I think of being at medical school in the 90s, in the 80s, I don't think I received a single day of training in smoking cessation. And I know many who go to nursing school or medical school or other professional schools receive very little training, certainly not training that is proportionate when we in terms of the premature death that occurs as a consequence of tobacco. And so if we can get get a paradigm shift where tobacco use disorder or tobacco addiction is seen as a co-occurring disorder, as a DSM-5 diagnosis that goes on the list, and there is integrated and suitably intensive treatment, then it's likely that we can shift this really dated approach to tobacco. There are some nice articles about this written. This wake-up call for psychiatrists was in a psychiatric journal a few years ago, again acknowledging that tobacco kills half of all psychiatric patients. It limits full recovery. Tobacco use disorder is a DSM-5 diagnosis and has a negative impact on treatment. So there have been attempts to try and shift the culture, but I think we've still got a bit of a way to go. One of the big obstacles in substance use treatment settings is the belief that patients don't want to quit. And there's lots of evidence that in fact that is just not true. You can see some of the statements here. These are just taken from a series of journals, but even in a methadone maintenance population, 80% were somewhat or very interested in quitting smoking. In an outpatient program for those who use alcohol, more than 75% were willing to consider stopping smoking. In patients with schizophrenia, the majority were interested in attending a smoking cessation group and appeared to be motivated. Now, expressing a desire to be free of cigarettes is not the same as having the confidence or the tools to be able to quit successfully. And there is a gap between those two concepts. But it's clear that when you ask tobacco users in these subpopulations that traditionally have been seen as not wanting to quit or unable to quit, in inverted commas, these patients actually would like to be free of cigarettes. And I think that's an important thing for us to understand. And so we talked about the self-medication hypothesis a little earlier when we were thinking about schizophrenia. But this is an important point that is increasingly reflected in the evidence in more recent years. And that is that patients with mental illness who quit smoking actually do better subsequent to quitting smoking than they were doing before in terms of their psychiatric symptoms. And this was best demonstrated in this very nice meta-analysis that was published in the BMJ in 2014 by Gemma Taylor and colleagues. I would encourage you to take a look at that. But essentially, this meta-analysis took a bunch of studies in which mental health was measured both pre and post cessation. And it was measured in a population of those without mental illness and in populations of those with mental illness. And what they found was that smoking cessation was actually associated with reduced depression, anxiety, and stress scores, and improved positive mood and quality of life scores. So maybe counter to some of these old beliefs that the inverted commas, these patients need to smoke cigarettes to relieve their symptoms. When we looked at this data set, when we did this meta-analysis, we found that those with mood disorders actually did better when they quit smoking. And that was seen both in those with and without mental illness. And the effect size was estimated to be similar to that of using an SSRI in somebody with a mood disorder, which is a pretty important observation. And it kind of poses the not necessarily a realistic scenario, but to make my point, if we are presented with patients with mood disorder who smoke cigarettes, and we go into our standard treatment approach and focus on treating their depression with an SSRI, in fact, we could reasonably approach their their tobacco use and their mood disorder by actually focusing on smoking cessation first, the effect size, according to this data, would actually be larger than starting an SSRI. Of course, we want to do both. And of course, that's going to be stage-based. It's going to reflect the readiness of the patient. But an important point from this meta-analysis that smoking cessation improves symptoms in those with mental illness. This is again just a selection of research that demonstrates that those who quit smoking when they enter substance use treatment actually have better substance use outcomes. Again, contrary to the belief that you can't do everything together, there is pretty good evidence that concurrent treatment, that is the treatment of both substance use disorders, the tobacco use disorder and the other substance use disorder, leads to better outcomes. The reality, of course, is that treating tobacco use disorder should be stage-based. So when our patients enter alcohol treatment, offering them concurrent treatment will lead to better outcomes for their alcohol use disorder. But it's dependent on the patient's readiness to consider treating both together. But the important point to make here, I think, is that we move away from the assumption that all things can't be done together, and actually let our patients know that they can have concurrent treatment and that concurrent treatment will not worsen outcomes and in fact may actually improve them. And sort of systematizing the offering of tobacco treatment as patients enter the system would be a good thing. Of course, this is kind of complicated now already by the fact that some of our facilities are smoke-free, so already people are getting nicotine replacement therapy for withdrawal management. But I think having a strong sense that concurrent treatment improves outcomes and trying to systematize that and educate around that is an important thing for us to think about. What do our guidelines say? Well, they say exactly that all smokers with psychiatric disorders, including substance use disorders, should be offered tobacco dependence treatment, and clinicians must overcome their reluctance to treat this population. This is from the American government guideline of a few years ago, suggesting that those with psychiatric disorders and substance use disorders should be offered all the same things: brief intervention, counseling, and pharmacotherapy. And our own Canadian guidelines saying very much the same thing. This is from Canadapt. Healthcare providers should offer counseling and pharmacotherapy treatment to persons who smoke and who have a mental illness and or addiction to other substances. This is brief intervention. Again, I'm sure you're all familiar with this. Just a small point that we should be thinking about systematizing these brief 2 or 3 minute interventions in all healthcare settings, whether they're settings within the mental health system or within the substance use treatment setting or anywhere else. Ask, advise, assess, assist, arrange. The 5 A's, there's 3 A's, there's 2 A's. There's a whole variation of these very simple ways to do brief intervention. Okay, so that's just a bit of an introduction, some thoughts about the specific populations that we've spoken of. I'm going to move on now to think a little bit about neurobiology and medications and how they work, and refer back to this brain slide again that I'm sure you're all familiar with. This section of the brain that we throw up anytime we're talking about any substance use disorder, actually. But as you'll all know, in those who smoke cigarettes, nicotine is inhaled very quickly, arrives in the brain within a few seconds, 7 to 10 seconds. It's that speed to brain that makes cigarettes so addictive. And that nicotine molecule lands on this alpha-4 beta-2 nicotinic acetylcholine receptor here in the ventral tegmental area. It lands in that receptor, it binds, and that leads to a release of dopamine and other neurotransmitters in the nucleus accumbens, which leads to an experience of pleasure. And that behavior is repeated, and pretty quickly, particularly in the young brain, there is an upregulation of these nicotinic acetylcholine receptors, such that when the supply of nicotine is interrupted, when the 14 or 15-year-old who's been experimenting with cigarettes for a few weeks decides that they no longer want to smoke cigarettes, when that delivery is interrupted, there is the emergence of a pretty predictable withdrawal syndrome, which includes irritability, anxiety, changes in appetite, and mainly craving. And the craving can be just thought of as this upregulation of nicotine receptors, creating a nicotine hunger. And the easiest way to eliminate the craving, of course, is to smoke a cigarette, land nicotine back in the receptor, and relieve those unpleasant symptoms. So this is in very simple terms what happens in the brain of a tobacco user. So let's just think for a moment about our medications, our cessation medications. So we have 3 first-line cessation medications in Canada, or 3 classes. And if we start in the middle with nicotine replacement therapy, that's pretty straightforward, whether it's patch, which delivers nicotine through the skin, or whether it's one of the short-acting products, gum, inhaler, oral spray or lozenges, which deliver nicotine through the lining of the mouth. All of them deliver nicotine back to that nicotine receptor, the same receptor where nicotine from a cigarette lands. And by doing so, by occupying that receptor, we eliminate or reduce the experience of craving and some of those other symptoms of nicotine withdrawal, and thereby make our NRT user approximately twice as likely to quit at 6 months compared to somebody who's using placebo or nothing. And so that's why NRT remains a mainstay of cessation practice. Standard dosing, 12 weeks, 21 milligram being the highest patch. But as we'll talk about in a few moments, certainly standard dosing is not the most efficacious way to use these products. If we combine products or go to higher doses, we tend to find greater cessation success. We'll come back and talk about that in a few moments. And then we'll just go to the bottom of this table. Varenicline, again, a drug I'm sure you're all familiar with. Champix is the trade name in Canada, Chantix in the United States. How does that work? Well, it's a partial agonist at that same receptor, at the alpha-4 beta-2 nicotinic acetylcholine receptor. What we mean by that is that its partial agonism turns on this pathway so that there is enough release of dopamine in the nucleus accumbens to reduce withdrawal and craving. But because it's a partial agonist, that means it's sticky at the receptor and it has an antagonist effect. So if our patient who is taking this medication smokes a cigarette, they find that it's really not very satisfying because the receptor is occupied by the varenicline molecule, so blocking the receptor in effect. And that's why we think that varenicline is an efficacious medication, because of that dual action of the varenicline at the receptor. And then, excuse me, if we just for a moment consider the third class of medication, so bupropion SR, bupropion slow release, also known as Zyban, which is a pill, and in fact is an SNRI, so not an SSRI, even though we use it as an antidepressant in its Wellbutrin guise, same drug, Wellbutrin and Zyban, both of them bupropion. It works as an antidepressant, as an SNRI, but in smoking cessation, it probably works by its reuptake inhibition in the nucleus accumbens of norepinephrine and dopamine, and thereby reducing the experience of withdrawal and craving. It probably also has some effects that are not very well understood at the alpha-4 beta-2 nicotinic acetylcholine receptor, but an efficacious drug, again, approximately doubling the likelihood of cessation in comparison with placebo in trials. Bupropion prescribed less commonly these days, one, because it doesn't have a great side effect profile. Any of you who've prescribed it will know that it can cause anxiety, it can cause sleeplessness and some agitation. And anyway, if you're going to prescribe a smoking cessation medication, an oral medication, it seems to make more sense to go with varenicline, which we know is more efficacious. But those are our 3 first-line treatments, which all have their place in contemporary cessation practice. Relative to each other, as I said, bupropion and NRT about twice as efficacious as placebo. Varenicline in studies about 3 times as efficacious as placebo. And NRT combinations, that is long-acting patch plus a short-acting gum, lozenge, or inhaler, also about 3 times as effective as placebo. It's not very often that I see someone who walked through the door and asked me to choose what approach I would suggest for their smoking cessation medications. Most people come with previous experiences, with experiences from family, from friends. Most people will say that they want A or B or C. But if somebody was asking me what I would suggest either combination or combination NRT or varenicline, based on the fact that those are the two most efficacious approaches. Certainly, we would be thinking about comorbidities with about a number of other factors. We might even be thinking about affordability, depending on which province you live in, and the kinds of coverage that you have available. But based purely on efficacy, combination NRT or varenicline will be the choice. Okay, so quick pause for breath. But maybe we'll just move on and talk a little bit about Eagles. Again, many of you will be familiar with this trial that was done in 2016. This trial was essentially done because of the noise around varenicline and the anecdotal evidence of neuropsychiatric harm that was caused to a number of individuals. There was a number of suicides. There was reports of low mood, hostility, erratic behavior. And so the manufacturers of the medication were asked by Health Canada, the FDA, the European medications agencies, amongst just a few, to do this trial to demonstrate whether in fact there was a neuropsychiatric risk and what the magnitude of that risk actually was. And you don't need to look too hard at this diagram, otherwise you may get a headache. But all you need to really know is that there was 4 treatment arms: varenicline, standard dose for 12 weeks, bupropion, standard dose for 12 weeks, nicotine patch, standard dose for 12 weeks, and placebo. 4 treatment arms, and this large trial of 8,000 patients was split into half of 4,000 individuals with no history of psychiatric disease and 4,000 individuals with so-called stable psychiatric disease. So these 4 drugs were tested both in a psychiatric population and a non-psychiatric population in an attempt to measure what this neuropsychiatric risk was, if in fact there was one at all. There was also some efficacy study done as well, but we'll just talk really mainly about safety today. And again, apologies for this table, but I'll just quickly walk you through the most important findings. So again, this is neuropsychiatric safety as the primary outcome of this study. And if we look first of all at the non-psychiatric cohort, as I said, 4,000 patients with no mental illness, or the non-psychiatric cohort, 4,000 patients with mental illness, this stable psychiatric cohort. And if we look across at the non-psychiatric cohort first, what we actually see is that there is no statistical difference across the 4 treatment arms: varenicline, bupropion, NRT, and placebo. Everybody fully blinded, no statistically significant difference. And in fact, if we look at the psychiatric cohort, the same thing, no statistically significant difference between the 4 treatment arms. Now, you will notice that the number of individuals in the psychiatric cohort who had neuropsychiatric side effects is quite a lot larger than in the non-psychiatric cohort, but there was no agent-specific difference. So there was no difference that was statistically significant between varenicline, bupropion, NRT, and placebo in the psychiatric cohort. Why was there a bigger difference? Why was there a higher level of neuropsychiatric side effects in the psychiatric cohort than the non-psychiatric cohort? Well, think about that from a practice perspective, maybe not entirely surprising. If we see people with chronic schizophrenia, or we see people with any mental illness and they quit smoking, we expect things to be more difficult. We're not surprised if the progress is a little bumpy. There can be neuropsychiatric events that relate to smoking cessation, but that's the reason we monitor this population when we support them through the process of smoking cessation. So the author's conclusions for this study: the Eagles trial provides evidence that varenicline and bupropion do not pose a neuropsychiatric safety risk, and these drugs can be used safely by smokers without a history of psychiatric disorders, and by smokers with stable psychiatric disease. And that's the little caveat here, that this population of those with mental illness were those that were defined as stable. And it's actually quite rare in clinical practice that we see patients whose disease is as stable as those in this study population. But that said, this does give us some comfort that the idea that varenicline is contraindicated in this population is frankly just not the case. The label on the product continues to provide a warning that this medication should be used with some caution and with monitoring, and I think that's appropriate, but this medication is not contraindicated in any population. Okay, and so I refer to NRT combinations. It's more efficacious than using one agent alone. It's common to combine patch with one of the short-acting preparations. It's safe. My approach in the clinical setting is usually to start with one product. Very rarely would I say to somebody, start with two, even though I know that's more efficacious than a single product. We put a patch on the patient and we see what happens. Now, if the patient quits with a patch on, great, they don't need another product. But if, as is not unusual, the pack-a-day tobacco user comes back and says, I've done really well, I've gone down from 20 cigarettes a day, but I'm still struggling with the last 2 or 3, it seems entirely logical to me to then add a gum or an inhaler to use at around the time that those last few cigarettes are consumed, or ideally before they're consumed. So combination NRT, a really common approach now, and arguably the most efficacious of all approaches. This is an important observation from these proposed label changes by the FDA some years ago, and that is the idea that NRT can be used while tobacco use is ongoing. The old paradigm of 2 decades ago, where we hand over the first patch to the patient and say that you need to quit smoking now and forever today, it has been problematic for many of our patients. In fact, I see so many patients who say that they have delayed their attempts to quit smoking by years and even by decades. And they would not have done so if they knew that they could kind of lean into a smoking cessation effort by putting the first patch on and not having to quit immediately, and seeing a reduction in cigarettes and then moving forward from that point, in comparison to that old approach of you got to stop immediately, otherwise you're going to have a heart attack. I mean, just not the case. And really, I hope everybody is now very familiar with this reduce to quit paradigm. Same as the methadone maintenance paradigm. We don't tell people that when we start them on 30 milligrams of methadone that they have to quit using heroin that day and forever. What we do is we start them on methadone, we build up their dose, we see their heroin use be extinguished sometimes over weeks and months. If we said that you had to quit on day 0, maybe we would have less people open to starting on that kind of treatment approach. So this is an important distinction to make between the newer and the older ways of doing it, and it's described here, this reduce to quit approach. Okay, this is just a bit of a tangent, and again, reminder for something that I'm sure you are mostly aware of. Cigarette smoking induces a liver enzyme system, the CYP1A2 system. And when I say induces, what I mean is kind of boosts the CYP1A2 system, which is responsible for the metabolism of many of the drugs that you see on that left side of this slide. Chlorpromazine, haloperidol, these older antipsychotics, but also clozapine, olanzapine, and caffeine are all metabolized by CYP1A2. The reason this is important is that in a pack-a-day tobacco user or a 2-pack-a-day tobacco user who are really giving their CYP1A2 system a bit of a boost, they're metabolizing these medications very efficiently. And when they reduce or quit smoking and that induction effect is lost, they're metabolizing the medications on the left of this slide less efficiently. And that means that their blood levels of clozapine, for example, are going up. Their blood levels of caffeine are going up. This is clinically usually most relevant in the context of clozapine. We need to watch for clozapine toxicity. It's uncommon, but not unheard of. And if you have a patient on clozapine who has quit smoking and starts to have symptoms of clozapine toxicity, drowsiness, drooling, confusion, then certainly think about the need to reduce clozapine or do clozapine levels, because the loss of induction effect of CYP1A2 has been, or the induction effect of CYP1A2 has been lost. And with heavy caffeine consumers who are quitting smoking, it's often a good idea to, at the front end, suggest a reduction in caffeine consumption to avoid caffeine toxicity. So when we see patients who are quitting smoking, who are getting agitated and edgy, we need to make sure that that's not in fact caffeine toxicity, which it might be. This is just a shout out from my local program or our local program here in BC. I know most of you are in Ontario. You have your own coverage of NRT through your various components of the STOP program, but we have blanket coverage for 12 weeks of NRT for every individual in the province. It resets every January the 1st, so you get one go per year, per calendar year. The same program covers the cost of varenicline and Zyban with some caveats. You're only covered if you've met your deductible, if you're covered by Plan G, which is our psychiatric medication plan, etc. This can be accessed by just walking into a pharmacy. Very straightforward and a very good program. We'd like it to allow combination NRT. We'd like it to allow longer durations of treatment. It doesn't, but we continue to lobby pretty unsuccessfully to this point, but you never know. Okay, so now just moving into some of the newer treatments, and in fact, this is not a newer treatment, but there's new attention on cytosine, also known as cytisinicline, which is I think can be described as a cousin of varenicline. In fact, the cytosine is entirely from a is entirely produced from a plant. So it's an entirely natural product, and it was on the basis of the cytosine molecule that Pfizer developed the varenicline molecule. So cytosine is also an alpha-4 beta-2 nicotinic acetyl receptor partial agonist. So it works in the same place as varenicline and works very similarly. And we now have a Cochrane review as of very recently saying that there is high certainty evidence that cytosine is more effective than NRT in promoting smoking cessation at 6 months. It's been around forever. It's been used in Eastern Europe. It's now available in Canada, but as a natural health product. So it's not a first-line approved smoking cessation therapy in the traditional pharmaceutical sense of the concept, but it's available as a natural health product from health stores. You don't need a prescription. You can buy it over the counter. It's very cheap. So compared to the $300 or $400 of a month of NRT or varenicline, it's about $50 for a 6-week treatment. But it's mainly not used because it has a pretty complex dosing regimen. It's 5 or 6 times a day in the first couple of weeks, even though there are recent studies looking at more simpler dosing regimens, which seem to suggest that it's quite efficacious, just dose TID. But this may well be a really good answer for low and middle income countries where the cost of our first line pharmacotherapies can be prohibitive. I typically recommend this for patients who say things like they don't like using medications, they want to use something natural. It kind of fits the bill for some of those patients, but it's something that I've prescribed or recommended on just a handful of occasions. I would always prefer varenicline in preference, with just those caveats. Okay, so that's about kind of a whistle-stop tour through medications. I did promise you that I would speak a little about the non-pharmacological approaches. This slide really is reflective of what I do in the smoking cessation clinic. It's just practical. It's hopefully thoughtful, non-judgmental, and is probably best described as tips and tricks. And the tips and tricks focus on the things that we always talk about in addiction and in relapse prevention, and that is the people, the places, the things, the situations, the circumstances, and the settings associated with smoking. The recommendation to change routines and to avoid these triggers. And for those who do crave, when they're presented with craving, using simple approaches like the 4Ds, the deep breathing, drink water, distract, and delay, to try and get through the few minutes of a given craving and come out the other end with a less intense desire to smoke a cigarette. So just really practical, common sense stuff that's well within the scope of a simple-minded physician like myself. Nothing that is rocket science. And then, of course, getting into more sophisticated counseling approaches, the kinds of things that we should be offering those who are much more ambivalent about making change. Those practical tips and tricks are fine for people who are in the action stage or the preparation stage, who are ready to go, who are putting a patch on, who are asking for help to quit. But for those who are umming and ahhing, for those who are not convinced that this is what they want to do, for those who we describe as being pre-contemplative or contemplative, motivational interviewing being the treatment of choice for ambivalence. And as I said, there are people who are far better equipped and far better educated in this area to talk about these approaches. I could talk for a great length of time, but I won't. But you see on the slide there the kind of the principal tenets of this approach: being empathic, trying to develop discrepancy between the current behavior and the changed behavior, and having the patient reflect and think about those differences. Where we see resistance, where we get our patients saying things like "no, but," we need to recognize that that's us pushing too hard usually, and we back off. And then we also support the patient's self-confidence or their self-efficacy. So these patient-centered approaches that are described sometimes as walking alongside the patient rather than kind of wagging a finger and imploring change are the ones that clearly we should be using in people who are trying to change any behavior, but may still have a semblance of ambivalence around that change. Okay, so getting into the last kind of section of this talk, thinking about the newer approaches to cessation, and nobody here has not heard of electronic cigarettes. It's something that you're probably sick to death of, frankly, after the last many years of hearing the pros and the cons and the fighting within the tobacco control community as to whether this is the holy grail or in fact is going to be the biggest problem that we're going to face in tobacco control in the coming years. Of course, the answers lie somewhere in the middle of all of those things. But the electronic nicotine delivery system, or the e-cigarette, is, as you see, this is a second generation device, a device that delivers nicotine not on the back of cigarette smoke, but within an aerosol or a vapor that contains many less chemicals than the many thousands that we see in cigarette smoke. The many thousands of which we know a number are carcinogens and toxicants. Well, aerosol or vapor contains a handful of components, flavorants, propylene glycol, other things. Just because there's only a few things in there doesn't mean that the e-cigarette is harmless. But if we accept the view of many health agencies, including Public Health England, who have made statements such as this product is 95% less harmful than a combustible cigarette, if we accept those positions, then we can very reasonably think about this device as a harm-reducing device. We can think about somebody switching from a combustible cigarette to an e-cigarette and reducing their personal risk. And in the event that they can't or won't quit smoking, it's very hard to see why we wouldn't be promoting the use of e-cigarettes in this population. And certainly in my clinical practice, for those individuals who can't or won't quit smoking, I absolutely will eventually reach the point of saying, have you thought about using e-cigarettes? Now, we can argue about how quickly that point should come, but I think anybody who's not recommending e-cigarettes for those who smoke cigarettes and are struggling to stop is arguably now out of touch with where the science is. This is just a little bit of a background as to how e-cigarettes have come to the fore. There isn't a source on this slide because I'm a little embarrassed to say that it actually comes from the makers of Juul, which arguably makes it a not and not entirely credible slide, but I think it makes a very good point. The graph shows us time on the horizontal axis. It shows us blood nicotine levels on the vertical axis. And if you just focus initially on this yellow line or the orange line, that's the blood nicotine levels that we achieve with a combustible cigarette. And as I said to you at the beginning of the talk, we know that cigarettes are highly addictive because they take just a few seconds to get into the brain. We get these big, fast arterial spikes with a combustible cigarette. And if you look at these two graphs down at the bottom, the blue and the green, those represent the blood levels achieved by the early generation of e-cigarettes. And you can see that there is no fast spike, and in fact, there's not a very high level of nicotine achieved at all. And that's really why, for a number of years, e-cigarettes didn't have much of an impact on our world. We were aware that they were there. We were aware that some people were using them, but for many years we were kind of uninterested because it didn't feel like they were particularly relevant, either in the context of use by youth or as harm reduction or cessation devices, until these pod type systems came along, which by altering the nicotine chemistry and using nicotine salts started to get the kinds of blood levels that you see on this pink line. And this pink line is the blood nicotine level that is achieved by the Juul. And you can see that they've pretty well achieved sort of the holy grail, which is a nicotine delivery that is very similar to that of a traditional cigarette, but without most of the bad things in cigarette smoke. So this is how e-cigarettes have really come to be part of our discussion. It's because of the evolution of the device to being quite an efficient delivery system. So what about e-cigarettes for cessation? So you've heard me talk about our first-line cessation therapies, varenicline, bupropion, and NRT. You've heard me talk a little bit about cytosine. But what about e-cigarettes for cessation? We know our patients are using e-cigarettes to try and quit smoking, but do they actually work? Well, this trial is the best known and arguably the most important. It's the one by Hayjack and colleagues that was published in the New England Journal of Medicine in 2019. And in this trial that was essentially set in the UK Stop Smoking Service clinics, which are scattered around the country, they randomized 886 people to either a second generation e-cigarette. So we're now at the fourth generation with these pod systems that give that very efficient delivery system. But this was with the second generation devices, which were actually really not that good. The refillable ones with the chamber. But even when we use that device and we compared it to NRT, and NRT was actually the choice to have combination NRT. So it wasn't suboptimal NRT, it was pretty good NRT. Their primary outcome was sustained abstinence for 12 months and biochemically confirmed, so involved blowing in a CO monitor. And the results they achieved at 12 months was that those in the e-cigarette arm with this second generation device had an 18% abstinence rates from cigarettes versus a 9.9% abstinence rate from cigarettes for those who used NRT. So certainly outperformed NRT in this trial, relative risk of 1.83. So on the surface, this looks really quite impressive. But there were some other interesting observations from this trial. At the 1 year mark, where the sustained abstinence rate was measured, around 9% of the NRT arm was still using NRT only, and around 80% of the e-cigarette arm was still using e-cigarettes. And this is something that was contentious. Some people pointed at this as a failure of the e-cigarette arm, but I think it can be reasonably argued that this is actually a success of the e-cigarette arm, in the way that we recognize the duration of Suboxone or methadone therapy as being the longer duration of the use of these products as being a good thing in addiction treatment, it may well be that we should view the long-term use of e-cigarettes as a good thing and contributing to the abstinence from cigarettes. So their conclusion was e-cigarettes were more effective for smoking cessation than NRT when both products were accompanied by behavioral support. So this is a somewhat pivotal trial that compared e-cigarettes with NRT. We now, of course, have many more trials, and as a consequence, we have a very recent review from the Cochrane group, who state unequivocally there is high certainty evidence that e-cigarettes with nicotine increase quit rates compared to NRT. Our own folks at CAMH in their lower risk nicotine use guidelines make the recommendation that e-cigarettes with nicotine may be an effective cessation aid for people who use combustible tobacco. A couple of the caveats on the right, my clumsily highlighted statement there: people who use combustible nicotine products should try to quit using first-line cessation treatments first. If they're unable or unwilling to quit e-cigarettes, can then be considered. So again, just reflecting what I said a few moments earlier about the kind of approach we take in our clinic. We try the first-line therapies first, but eventually we need to get to e-cigarettes as an option for those who can't or won't quit. This is a very nice editorial just from last week in the New England Journal of Medicine. Again, I'd encourage you to read this if you're interested, by Nancy Rigotti, an editorial which is titled "Have We Reached a Tipping Point?" And the conclusion there: clinicians should be prepared to have a risk-benefit discussion about e-cigarettes. The evidence has brought e-cigarettes to a tipping point. The burden of tobacco-related disease is too big for potential solutions such as e-cigarettes to be ignored. So that's the case for, and clearly it's pretty impressive in terms of the accumulating evidence for e-cigarettes as an efficacious cessation tool, and even conceptually as a harm reducing tool for those who just switch away from lethal combustible cigarettes to what is almost certainly a less harmful product that may be used for a long duration. But the flip side, and many of you will already have been thinking about this over the last 3 slides, there is a flip side, and here it is. So if we look at the graph on the left, we see the use of e-cigarettes amongst youth between the ages of 15 to 19. And this is past 30-day use. So the question is, have you used an e-cigarette in the past 30 days? And if you say yes to having used once, then you get captured by this graph. And so for past 30-day use in the 15 to 19-year-olds, you can see that in 2019, we had a prevalence rate of around 15%. By 2022, it's gone down a bit, but it's still hanging around at about 13%. When we look at the next graph and we look at the 20 to 24-year-old age group, we see that e-cigarette prevalence has gone from around 15% up to around 20%. So clearly, there is a pretty high prevalence of e-cigarette use amongst young people. And this is why we have this sort of legislative dance around what to do about e-cigarettes. Health Canada most certainly wants these products to be available to those who smoke cigarettes and who want to pivot away from them, either by using e-cigarettes for cessation or as a less harmful option, but they also want to protect youth. And this is why we see initiatives that reduce the concentration, the maximum concentration of nicotine in e-juice from the 50-odd milligrams per mil that it was a few years ago to 20 milligrams per mil now. This is why we see the provinces doing all kinds of different things around flavors to restrict appeal to youth. These are the reasons that we're trying to find the right balance to allow access to adult addicted smokers whilst protecting youth. Now, you may argue that we haven't done a very good job, but this is the conundrum that not only Canada is facing, but all developed world countries where e-cigarettes are being used. This is the real question, of course. The past 30-day use is interesting. It tells us how many youth are experimenting with e-cigarettes. But when we ask a second question of those who say, yes, do I have used in the past 30 days? And the second question is, have you used for more than 20 days in the last month, we see that quite substantial numbers are using on a quite regular basis, almost daily. So 28% from this US FDA study in 2018. So 28% of those who've used in the past 30 days using almost every day. And in my clinical setting, we're reasonably regularly seeing young people who are asking for help to quit using vapor products. There's a couple of problems though. One is that many of those are brought along by parents, and the young e-cigarette users themselves are often not very motivated to make change and often don't see there being a great problem. And even for those who do want to make change, in my view, the environment that they're in is really not conducive to change, and that the environment being school, where e-cigarette use is clearly out of control. So the approach I use, and I know that many others use, is mainly starting with short-acting NRT, but I have to say, not a great deal of success with youth who use e-cigarettes at this point. So we'll just finish off by talking for a couple of minutes about something that's been in the literature recently. In fact, in yesterday's CMAJ, there's a very nice review article about RTMS, or repetitive transcranial magnetic stimulation for smoking cessation. The evidence for this approach has been growing for some years. In fact, it's been around for decades in the treatment of mood disorders. One coil has recently received regulatory approval in Canada in 2022, the so-called H coil, which has been able to provide deep magnetic stimulation to the brain, and has managed to get into parts of the brain that are implicated in addiction, namely the insular cortex. But clearly there's a lot of obstacles to this expensive technology kind of reaching the coal face of the clinical world. I actually reached out to a colleague who works at VGH, and who I know uses an RTMS device for the treatment of refractory depression, to ask him if he may be interested in thinking about applying it for smoking cessation. But the answer I got was that they were overwhelmed with demand for their tool, and it really wasn't going to be available anytime soon for me to bring my tobacco using patients to use. I know that the folks at CAMH are starting to use this approach. There's trials, I think, about to start. But certainly an interesting new area within smoking cessation. This is the pivotal trial, really, that has really raised the interest in this approach. This is from Zangad and colleagues. It's an Israeli trial from 2021. They had 262 tobacco users who met DSM criteria for tobacco use disorder, and those individuals were exposed to 3 weeks of daily RTMS or sham RTMS, and then after the daily 3 weeks, were then exposed to once weekly for a further 3 weeks, so 6 weeks of treatment. And when those who had received active treatment versus those who received sham treatment were compared, using continuous quit rate, so quit continuously for 4 weeks until week 18 was the criteria for success, 19.4% in the active group versus 8.7% in the sham groups. So certainly quite impressive looking at those numbers. But these relatively short 6-week treatment periods have not been demonstrated to achieve long-term cessation. So when you look at all of these studies at 6 months or longer, there's actually no difference between active treatment and sham treatment. But again, we're very early in this process, and clearly we need to see more trials, and we need to see more trials taking different kinds of approaches. There's a recent trial from the folks at CAMH, which has used varenicline plus RTMS. And I can't remember whether, I think it's at 4 weeks only, but at 4 weeks, the varenicline plus RTMS group had 80% cessation rates compared to 30% in the sham arms. So there's clearly something in this. And now that Health Canada have approved this device, this H-coil that does the deep magnetic stimulation, I think we're going to see much more. And again, if you're interested, take a look at this week's CMAJ. There's a nice article in there. These are the folks who make it. Brainsway, it's a global medical device company. Go to their webpage, some interesting stuff about this. Okay, so I'm going to stop and try and allow, as I said, 20 minutes for questions. I'm almost on time. If you want to find me, you can email me at the email address that you see there. You can follow me on Twitter, but you might hear more about my English soccer team than you'll hear about smoking cessation. But there is some smoking cessation thrown in there, and that's where I spend my clinical time these days. So I will hand over to Jennifer.
Thank you. That was great. I have so many questions. I think before going back to some early ones, I'd like to continue on the e-cigarette theme because there were quite a number of questions there and a lot speak to, I guess, my own lack of knowledge as well. How would you compare the strength and the use of e-cigarettes with nicotine inhalers? Is that a fair question?
It's a great question, and I'm going to jump back a few slides and show you this very nice page from the lower risk nicotine use guidelines. And if you look in the considerations, there is a bullet, the third bullet down, that says there is no evidence for a specific device type or amount of nicotine that is most effective for cessation, which is terribly unhelpful. But I think it's the reality of where we're at. And that is that there is no evidence to guide us when we say to our patients, have you considered using an e-cigarette? And that is a terribly unsatisfactory place to be, in my view, for us to say to our patients that this might be a better thing for you to do. And when our patients then say to us, well, what device, what dose, where should I get it from? For us to then say, sorry, buddy, you're on your own, is a really difficult place for us to be. But I think that is honestly where we're at. And the variability of these devices and the lack of regulation means that trying to do any kind of equivalence is pretty well impossible. So if the question is, what is the equivalence between an e-cigarette and a nicotine inhaler? My honest answer would be, I have no idea. Now, that may seem like a sort of an unserious response to the question, but let me tell you what I would actually say in reality. I would really promote the idea that people use these devices when we're recommending e-cigarettes, that they use these devices in an incremental way. So if you get yourself a 4th generation pod device and you're trying to quit smoking, use it as much as you need to use it, because it's about nicotine delivery and replacing the nicotine that your brain has got used to receiving. In the same way that we recommend nicotine gum. I don't tell people they can use 4 pieces of nicotine gum a day or 6 pieces of nicotine gum a day, or even the 8 pieces that are recommended by the manufacturer. I say use as much as you need to help you to eliminate cravings and stop smoking. The worst thing that can happen is that you use too much. Well, first of all, you won't use too much, because if you use too much, you'd become nicotine toxic and not feel very well, and then you would stop. But even if you did do that, nothing bad is going to happen. Nicotine toxicity never killed anybody. So I'm giving you a very lengthy answer, but the answer to equivalence is that equivalence is almost impossible, whether it's between NRT and e-cigarettes, or really any other of our standard approaches. And mostly we're making it up as we go along with our attempts to find equivalence. Even equivalence between cigarettes and patch dose are really not very good, right? I mean, the way that patch doses were initially were recommended were based on the idea in from clinical trials very early in the game back in the 90s, where it was thought that a cigarette contains 1 milligram of nicotine, and if a person smokes pack a day, that's 20 milligrams of nicotine. So we should give them a 21 milligram patch.
Mhm.
Well, that's kind of a bit of a weak, a bit of a weak argument because you're comparing nicotine going through the lungs when inhaled from a cigarette to nicotine going through the skin and the venous system to the brain. So how do we get, how do we compare and create equivalence when we're using two entirely different delivery systems and delivery processes? So
But it
long
would
story short,
be interesting.
sorry, carry on.
I was going to say, maybe we can't convert it into NRT equivalents, but I think, especially when you talk about youth using e-cigarettes or vaping extensively, it would be interesting to be able to use the example of a comparison in the number of cigarettes or packs per day, because there is this perception, as you've said, that it's not smoking and it's safer, and clearly it's not combustion. But what are the other sort of downsides, and what's the risk of developing dependency? So I guess maybe to your point, it's a little bit moot when it comes to the NRT replacement, but is there any equivalence in terms of, that 20 milligram cartridge?
Right,
Is that worth
right.
trying to compare?
Yeah. And again, anecdotally, there's been a lot of description of how one jewel pod seems to equate to a packet of cigarettes a day. And when you ask people who go from cigarettes to vaping, that can give you some sense of equivalence, right? So a pack a day guy who says he needs a pod a day, well, that's kind of telling you that a pod a day might be equivalent to a packet of cigarettes a day. And I've seen a fair amount of individuals who've said things along those kinds of lines. The problem with youth, of course, is that the way they use these products also complicates matters. A tobacco smoker has one every couple of hours, while youth are grazing on these products just all day long.
Yeah.
And so that's just another variable, right?
I've seen that in some adults as well. And in particular, I can think of a few people with more significant mental health issues. And now that we see people on video, right, they're not in our offices. Sometimes we can see them walking around and how often they're puffing. So you mentioned compulsive vaping at the beginning. And I'm wondering if you could talk a little bit about how to help people who seem to recognize that their vaping is a little bit out of control. And then sidebar, I have someone else who has not been smoking for years, but his nicotine gum chewing is constant. I'm sure it's giving him all kinds of GI effects that he thinks are related to other things. So, you spoke about how we don't limit people, tell them to use as much as they need. Is there any guidance around when it's too much and how to begin to taper?
Yeah. That, so I think you had two questions there.
Mm-hmm.
Your first one was about compulsive vaping and certainly where we recommend using short-acting NRTs. I don't think there's any guidance as to amounts at this point, but to your point, it's really a case of replacing. So use as much as you need. But there's certainly a population who will compulsively overuse anything, right? And I know that when a few years ago I was really encouraging some of our psychiatric wards at VGH to make access to short-acting NRT really easy. And rather than having to come and plead at the nursing station every hour for a piece of gum, we were sort of trying to encourage these approaches where it was like left out in bowls for people to collect whenever they wanted it. And I think what I had underestimated was the amount of compulsive use of anything that happens in this specific population, and the NRT just disappears sort of instantly because people will just use because it's there. But I think actually with NRT people don't generally overuse because it makes them feel unwell beyond a certain point. And you talked about the GI side effects. I mean, that's not uncommon when people use their nicotine gum, particularly when they use it incorrectly, right? When they're not doing chew and park. But I've had a few patients over the years who have got stuck on their short-acting NRT, who come back and say, I've been using it for 5 years. I'm worried about what it's going to do to my to my oral cancer risk or whatever. And the answer for those populations is usually to say, look, if you can taper it and stop, that's a good thing. But if it's the only thing that stops you from going back to tobacco use, to smoking cigarettes, then just carry on using short-acting NRT, because the risk is somewhere between 0 and very small. And of course, the risk of smoking cigarettes is massive, right? So again, I think these are all sort of well-established principles. I hope everyone on this call is not hearing this for the millionth time, but if you're needing to, to think about, or if you're thinking about how to answer those questions about long-term NRT and people worrying about their long-term NRT use, I think often the answer is just be my guest, right? If it stops you from going back to smoking, be my guest, continue using it. It's like the patient who says to you, I've been on methadone for 7 years, doctor. I feel like I need to come off. Well, sure, if you need to come off and you want to come off, we can try and taper you off methadone. But if it's going to predispose you to relapse, or if you've relapsed every time you've come off methadone before, you don't ever have to come off.
So I think in a way that makes this next question a little bit less relevant, but there was a question about what are the stats on return to cigarette use, so smoking, after cessation with NRT or e-cigarettes. I hope I asked that question properly, Katie. So what is called relapse rate? I think that goes back to that you were showing from the UK.
So almost all our cessation trials don't have long-term outcomes. Their long-term outcomes are at 6 and 12 months. And if you're looking at a Champix trial, you've got cessation rates of 20-ish%. If you're looking at a Champix plus NRT trial, there are some small trials that look at Champix plus NRT. You're looking at sort of 30% cessation rates. But these are usually out at about 6 months. And knowing what we know about addiction, there's clearly going to be a relapse rate, right? Now, knowing how big that is actually very difficult to know. But treating addiction means that relapse is going to happen. And tobacco use is no different to any other substance use disorder.
Quick question before we open the mic to Marilyn. Question about people who smoke smaller quantities. So 1 to 5 cigarettes a day, but having difficulty quitting on their own, not necessarily interested in medications. Do you recommend patches? If so, what strengths and how to use lower strengths of other kinds of nicotine replacement, I guess, in those individuals?
Yeah, good question. So patches are actually not approved officially, according to the label, in those who smoke less than 10 cigarettes a day. Now, that doesn't mean you can't use them. You certainly can. But for people who smoke just a few cigarettes a day, certainly I'd be exploring the kind of behavioral element of it. I mean, is this something that is due to routine? Is it due to the morning cup of coffee? Is it truly a physical dependency? Is the way out of the 5 cigarettes a day or the 3 cigarettes a day good counseling? Or in fact, is there a need for the use of NRT? There's not a lot to lose by using NRT. And for those patients, I would typically be encouraging the use of short-acting NRT. But if somebody's smoking 5 cigarettes a day and we recommend short-acting NRT and they find they're using 4 or 5 pieces of gum a day, and then they say they'd like to use the patch, again, not a lot to use by moving to a small patch, a 7 milligram patch. If it's too much, the patient will feel uncomfortable. They'll be nicotine toxic, but again, that would be very improbable. This is all outside of label because patches are not recommended for those who smoke less than 10 cigarettes a day. But these are the kinds of approaches that you might use in a clinical setting where you're just cautiously introducing NRT for those who want to try it.
Mm-hmm. Marilyn, welcome. You have a question.
Yeah, hi. A question and a comment. I mean, one of the comments, the mantra from the Ottawa model from Dr. Pipe is using nicotine replacement as much as it takes for as long as it takes. And the other is around using short-acting nicotine replacement, and also even the vape for people who seem, who really don't have the ability to don't have impulse control. We used nicotine spray during the pandemic with residents of long-term care homes, and some of them we gave them the nicotine spray, and some of them went through a whole bottle in a day. And once it was controlled and sort of doled out on a regular basis, and people had sort of stabilized serum nicotine levels, then less behaviors and the mental health became stable as well. So the issue that I have with the vape is that for some people it works really well, but you can't really tell how much you're having. And like young people, you mentioned, young people just sort of toke on it, but there's not a real sort of consensus about how much, when how many puffs equals one cigarette. And so some of the vape stores can sell you a pen that has like 10,000 puffs in it, and that's works out to, over a course of a week, 92 cigarettes in a day. So, but we're not really educating people about that, 10, 15 puffs, but, use it the same way as you would a cigarette so that you're not taking in more nicotine. Because I think there was some research that was presented at the Ottawa conference last month that suggested that people actually increase their nicotine levels by using the vape.
Yeah, I mean, those are all good observations. I certainly would consider myself of the Andrew Pipe school that use as much NRT as you need, and for as long as you need it. Those are absolutely principles that I would agree with. And yeah, you're right about vaping, that this is the Wild West with devices that are doing all kinds of things. We've seen this growth in these single-use devices now to get around some of the regulations that have come along in recent years. It's a largely unregulated market, and what kids are using is absolutely terrifying. And my guess is that I made a couple of comments about how I've seen not a lot of kids, but some kids, and they're often there reluctantly, and we've not had a lot of success with these kids. But I guess based on how many kids are using nicotine on a regular basis, we have got probably a tsunami of clinical work to do in the next few decades, where these 15 and 16-year-olds become 20 and 30 and 40-year-olds who don't want to be vaping anymore, and are going to be presenting and are going to be motivated to make change. And then we're going to be presumably using our vareniclines and our RTMS and whatever else is in our toolbox at that time.
So quick question before I go back to some questions about cysteine. We talked about use as much as you need for as long as you need. What about multiple patches? Any comments on how high you can go and what to watch for?
Yeah. So again, anyone who's heard Andrew Pipe talk about this will have heard these remarks. I mean, you can go as high as you need to. Typically, you start at the on-label maximum dose of 21 milligrams. But in heavy tobacco users, you're not surprised if you need to go to 2 patches or even 3 patches. I've had people on 321s, but they've typically been 2-pack a day or heavier smokers. They happen to often have schizophrenia, which may or may not be relevant. But depending on the nicotine consumption of the individual, you may need to go up much higher than 1 patch. And you can use for any duration. I think to be seen as being a judicious practitioner, it's a good idea not to just slap 3 patches on anyone. I think if someone is smoking 2 packs a day and you expect to end up on more than 1 patch, start on 1 patch and review in a week. If you're in a hospital setting, you may do it much more quickly, of course, and many of the in-hospital protocols have got allowance for these much more aggressive dosing schedules. But absolutely, you can patch beyond 1, 2, even 3 patches is not unheard of, and not something that I haven't seen.
I guess that gets me back to something you mentioned earlier about trying to get people, or encouraging or supporting people who are trying to manage multiple substances at the same time. So in a withdrawal management setting where people are detoxing and not allowed to smoke, that forced withdrawal adds such a big element. I guess I'm wondering about any strategies specific to those environments.
Yeah, so the 2 strategies really. The first is that where there is enforced abstinence, the messaging needs to be absolutely clear that we are not making you quit smoking. We are managing your withdrawal. So the perception that some patients have is that they're being made to quit, in inverted commas. And what we should be saying is that these patches are designed to make you comfortable whilst you are in this dreadful place that you don't want to be, and you are forced to not smoke cigarettes. What you do when you leave is, of course, your choice and your right. This is designed to make you comfortable. This is withdrawal management. That's the first piece of the messaging, and I think it sometimes gets confused because we use the same product for cessation as we do in the hospital setting for withdrawal management. Sometimes the messaging around it gets confused. So that's the first bit. And the second part of it is to treat aggressively. You know, is if somebody smokes 2 packs a day and they come into hospital and someone puts a 14 milligram patch on them, well, it's a waste of time. They're going to probably need a 21 or 2 21s or 2 21s and a handful of gum. You need to get quickly with hopefully supportive protocols in these settings that support aggressive treatment to keep people comfortable, because we can keep people comfortable. There's no reason why somebody should be outside of a hospital in -40 with an IV pulse smoking. We can keep people comfortable if we treat aggressively enough.
I have a whole bunch of questions, but I recognize that it's 8:31 and you are not feeling great. So we can jump off, or if you've got another couple of minutes, I can see a couple more questions in here.
Yeah, I'm happy to stay and do a couple more, and I'm also happy to have them forwarded to me by email. But yeah, let's certainly we can stay for now.
So let's say no more than 5 minutes. You're talking about people in hospital, or let's say withdrawal management, and having gum and having other things in addition to patches. In my experience, hospitals now often have patches. We can order that, but not those other forms of short-acting NRT. Is that something that's available in hospital settings in BC, or how have you managed working around that?
Yeah, no, we have the short-acting products available on our formularies here in Vancouver Coastal. Yeah,
Okay.
and we've never not had them, to be honest. There's I think as one of the folks said in her questions earlier, the inhaler and the sprays seem to have particular attractiveness for some of the psychiatric populations. I've heard that anecdotally a lot over the years, but those things are good to have for sure on your formulary.
Okay, I need to look at my formulary. Do some of the medications used to treat schizophrenia cause an increase in cravings for nicotine?
No, I don't believe that is the case. But if we turn it around, and you recollect my point about the CYP1A2, those medications that certainly the old antipsychotics that caused side effects, the blood levels of those were pushed down by smoking. So the more you smoked, the less unpleasant side effects that you got from those medications. And so that may have been promoting the use of tobacco in that population.
Got it. Question on whether vaping or e-cigarettes are associated with pulmonary embolisms.
No evidence that vaping is associated with pulmonary embolisms,
I don't think so.
and no reason to believe that that will be the case.
Yeah.
So at this, so again, for clarity, I couldn't really get into the depth of every aspect of vaping, but one of the things that would be useful to say is that at this time there is no disease entity that is known to be caused by vaping. So we can't say that vaping causes COPD. We can't say that vaping causes heart disease. That there are some studies that have demonstrated markers of concern that might translate to some of these significant medical conditions, but at this point there is no conclusive evidence to support that. Now, whether that changes over the coming years, it may, but just conceptually, based on what is in aerosol, the risk should be substantially less than that posed by cigarettes. And I think most people now get that, but there is still amongst the general public this confusion about whether vaping is as harmful as cigarettes or more harmful than cigarettes. And I think we need to be careful that we don't inadvertently reinforce that messaging. We need to say that vaping is not likely to be a risk-free behavior, but it's almost certainly significantly less harmful than smoking.
That all makes sense, but I'm thinking about a few years ago when there seemed to be this sort of flurry of interesting articles about pneumonitis or lung conditions caused by other sort of particles, right?
Right.
Liquids and
Right.
oily materials. Yeah.
Yeah, and so of course that again was a specific phenomenon that related to vaping THC and was thought to be due to an oily substance within that product, vitamin E acetate, that caused those that cluster of very serious lung conditions with a number of deaths, particularly in the US. So, I mean, yes, that some bad things have happened with vaping, but that's a specific phenomenon that doesn't really relate to the current use of products like Juul or Puff Bar or these products that are being used by youth today.
Last, cytosine side effects, contraindications.
So cytosine has very few side effects. They're kind of similar to varenicline. So GI side effects, sleep disturbance, no contraindications that immediately spring to mind. I think it's safe in almost every clinical situation. Yeah, something to keep in the back of your mind as an option. But the dosing's a bit of a drag.
Okay, sounds like something for people to Google, and thank you for being generous about sharing your email and ability to contact you and follow up. Thank you for your time, especially recognizing that you're not feeling very well. This was a big energy expenditure, but very much appreciated, full of very helpful, practical tips. We thank you so much. To our audience, thank you for joining us. Please join us March 20th. We're talking about considerations in the care of people who use stimulants, including approach to stimulant-related psychosis with Tanya Hawk and Stephanie Rochon. Have a great night, everybody, and be well. And thank you again, Milan, and feel better.
Thank you. Bye-bye.
Good night to everyone. Fill out your evaluations, please. Is the recording off, Laura?